So it's my pleasure to introduce Dr. Rachelle Bernacki to all of you this morning. Dr. Bernacki is the Associate Director of the Serious Illness Care Program in Boston and an Assistant Professor of Medicine at Harvard Medical School. Dr. Bernacki will introduce us to the Serious Illness Conversation Guide and help us learn how to initiate and accomplish difficult conversations with seriously ill patients. These are important, intentional conversations about illness, clinical options, and appropriate clarity around prognosis. Also, equally important, if not more so, a conversation about goals and values and wishes. What matters most to the patient as he or she traverses this very new territory. We're going to learn that these conversations are not easy. In June of 2015, I was privileged to go to Boston and attend the first Serious Illness Conversation Conference. And there, the guide created by Dr. Bernacki and her colleagues, Dr. Atul Gawande and Dr. Susan Block, we learned about these conversations, and we learned that not only are they not easy, but we've really never been taught how to have these conversations very well. And often, we don't get to the goals and the values and spend a lot of time on clinical options. We're not very clear about prognosis, and this isn't very helpful. So there's lots of good things for us today in Dr. Bernacki's presentation, and I'm very pleased to introduce her to you.
It's great to be here, and thanks so much to Mike for inviting me. It's really a wonderful community here, and I really have enjoyed planning this, and you have a great group of people here to do that. So I'm really delighted to be here and share some of the work that I've been doing for the last few years, and I have nothing to disclose. Today, the idea, for the first 45 minutes today, I'm going to talk to you about a program that I implemented at my home institution, which is Dana-Farber Cancer Institute, and talk about what happened with that program and some of the results of that. And then we're going to move into a different phase where we demonstrate what we actually did in the program, and we have some great volunteers that are going to help us. And then we're going to break up into small groups and actually try using the guide. So the objectives today are first to talk about the rationale about why we need a systematic approach to improving conversations about values and goals with patients with serious illness. Then I'll talk about the Serious Illness Care Program that I developed with colleagues in Boston. And then I'll talk about some of the data. And it was kind of fun. Mike was just saying this morning, he came to our course last June and he saw one version of this presentation, and then he saw it again yesterday, and he was like, wow, you really have a lot more stuff now, and that kind of felt good. So we're moving along. Okay, so you probably all know this, but and see this every day in your practice, but aggressive care for patients with advanced illness can really be harmful for patients. They can have lower quality of life, they have greater physical and psychological distress, and their caregivers get depressed and they have less satisfaction. We know, unfortunately, that people don't have these conversations, or if they have them, they happen late in the course of illness. So I'm talking about cancer patients because that's where we have the most data. So in cancer patients, fewer than a third discuss their preferences with their clinicians, and often these conversations happen about a month before death. And I did clinical palliative care for 10 years, and I felt like I was sort of running around at the last minute trying to fix situations that had kind of spiraled out of control, and it was actually impossible to do so in the time that you had. And when this opportunity came up to work on this project, I was really thrilled because I felt like it would be using my skill set in a different way. And I'll talk a little bit about how this project came to be, because I think it sort of helps you understand what we're really trying to do. I work with Atul Gawande and Susan Block, and Atul writes a lot for the New Yorker, and he was writing an article about 5 or 6 years ago now about what can we do when we can't cure a patient's illness. And he was really asking sort of a philosophic question, what should we do? And through that article, he interviewed my mentor, Susan Block, and said, and I find this question really important because he's a surgeon, and he said, I really don't have good conversations with my patients who are seriously ill, and I'm not really sure why. And I think that was key. And Susan asked a question, and she said, well, what questions do you ask them? And he told her. And so she said, maybe you could try this set of questions. And he went back and he had a conversation with his next patient, and it was completely different. It was a transformative conversation for him, and he really felt like we should teach everyone this set of questions. And the questions were not rocket science. They were things like, what's your understanding of your illness? And if time were short, what are your most important goals? But to really sort of frame shift the conversation away from procedures and more towards what the patient values and what's important to them. And so then he and Susan said, well, we need to find some money to do this. And he went to Partners Healthcare and asked for a small kind of seed grant, and that's where I came in. And they said, well, we want to do this, but we really don't have time. and so then I started working on the project, and this is sort of the results of that project. So for patients with advanced cancer, they have these conversations that happen about a month before death, and often the people that know them best, like their primary care provider or their primary oncologist, isn't having the conversation. It's actually a doctor in the hospital. So for cancer patients, 55% of the initial discussions about end of life occur in the hospital setting. And then when we looked at conversations, they often failed to address many key elements of quality. We know that there really is a mounting evidence that early conversations are associated with better outcomes. And Mike talked about this, the study that was done at Mass General. We know that those patients lived longer, they had better quality of life, they had higher satisfaction, but the evidence base is really growing to include many more studies to see that palliative care leads to fewer hospitalizations, patients and families cope better, and we have improved bereavement outcomes. Why are earlier conversations better? What do you think? Why do you think that patients do better if they have an earlier conversation? Any ideas? Yes?
They feel better because they can feel a little more clearly.
Fantastic. So they have less symptoms. They feel better, so they're able to think clearly. And so the question was, why are earlier conversations better? And she said it was because they feel better, they can think more clearly. So oftentimes, when patients are in the hospital, and if they're 33 days, the incidence of delirium is really high symptom burdens, and they can't really, and mostly at that point, you're in a crisis, and people can't think when they're in crises. So
I think it's also better because patients may have time to do things that they want. And that will 33 days before they die.
Right.
Yeah.
Right. Exactly. Right. So so just to rephrase, if you have more time, you can do things that they want to do. And if you wait until the last month or bedbound, you can't do the kinds of things that are important. Yes?
I would say that it allows people to have a conversation that is probably already going on in their own mind. And it also normalizes it so they can then begin to talk about it with friends and family.
Yes. So it takes people time to sort of try this idea on in a way, and they need to sort of work it through their own psyche, and then they can talk more with their family and friends about it. I think that's really important. Yep, go ahead.
I think they may also make different choices about medical therapy and choose less aggressive therapy that may be completely futile and affect their quality of life at the end.
Right. So having early conversations may lead to different choices about therapies. I think that's absolutely right.
Often the thing that prompts the conversation is a regrettable intervention. And so the conversation a little earlier avoids that intervention or interventions.
Yep. So unfortunately, the way things happen now is something happens, they get admitted, they get a procedure or something, and that prompts the conversation. And sometimes you're lucky, that might happen early and you still have some time, but oftentimes it happens late and then you can't do those things. So you guys are all, yes?
I feel like it also builds the conversation that you can have a conversation with your provider and kind of sets the tone that anytime what you want changes, you can always talk to your medical provider about that.
Yeah, it opens a door.
On the same page.
Fantastic, absolutely.
I also think that it gives the families more time to process because often they are very impactive on the patient's decisions, and so in the the late 30, 33 days, you've got families that are in panic mode,
Yeah.
and they're trying to, resolve this situation. And early on, it just gives the families time to support their loved one.
Absolutely. So this is really much better, not only for the patient, but also for their families. Said beautifully. All right. You guys are all very astute. Okay, so if we know that there's all these good outcomes from having early conversations, then why don't they happen? So I spent a lot of time thinking about this, and it was very frustrating to me. We also know that palliative care can do this, right? So palliative care clinicians or palliative care providers can have these conversations. They have training and skill set to have them. However, we'll never have enough palliative care clinicians to have all the conversations that need to happen. We have like 11,000. I worked on the workforce study through the American Academy of Hospice and Palliative Medicine, and we have a really critical workforce shortage, especially with the demographics that we have right now. So we won't have enough people to have these. So really we're going to be relying on primary care clinicians, oncologists, nephrologists, cardiologists, and many other disciplines to have these conversations. And so what we need really, I think, is scalable interventions, or interventions that raise the bar for everyone so that we can have more conversations and they can happen in a more timely way. Does that make sense to people? Okay. So just a little bit on terminology. So I think that advanced care planning is great. I think of advanced care planning as advanced care planning in advance of serious illness. So, when you have a baby, you sign a healthcare proxy and you sort of talk with your spouse about what might be important. But a conversation for someone with serious illness is pretty different. So when you have a serious illness, there's much more. I think there's many more elements to the conversation, and it needs to go into greater depth. So when I'm talking about serious illness conversations, and when I'm talking about patients with serious illness, I'm talking about patients with a life expectancy of about 1 to 2 years. And the terminology we use here, goals of care discussion, is a discussion that happens often in the hospital when you have to make a decision. Serious illness conversation, we're trying to move these conversations upstream to happening when someone knows that they have a life-limiting illness, but perhaps still has a year or 2 left of life. Does that make sense to people? I see a lot of nods. Okay, so now I'm going to talk about the structure of the serious illness trial and our intervention components. Okay, so when I first got asked to work on this, our first name for this project was the Palliative Care Checklist, and the palliative care side of me really sort of ruffled my feathers to think about a checklist. And I told Atul that, and he was like, and the reason we called it a checklist is because we had a surgery checklist where, every time you went in and did surgery, you would make sure that everyone knew each other's names and we were operating on the right side. And it was actually checking off the boxes. And the way I was envisioning this checklist, it wasn't going to be a checklist where we ticked off the boxes. And he was like, well, okay, I think that's okay. But I actually became a convert in this idea of having sort of a guide of what you go through in palliative care. And I think the reasons for that, I got to work with a Boeing engineer who makes checklists for flying airplanes. And, landing a plane is a very stressful situation. It's high stakes. When we have conversations with patients with serious illness, it's also a stressful situation. It's stressful for us as the clinicians, it's stressful for the family, it's stressful for the patient. So having a guide to sort of walk you through what you should be doing can really reduce the anxiety for you as the clinician, but it also allows you to kind of know where you're going and also sort of listen better. And that's what I've really seen the most with watching people use this is they feel a little bit more relaxed because they know what they're supposed to do, but they also can really listen to what the patient is saying. The other thing is I think that many people don't know what they should be talking about, and it gives people better focus and content and what they should talk about in the conversation itself. the other thing that was impressive was I got to watch a lot of people do these conversations, and I would have them do it sort of their usual way, and then I would give them the guide and have them try it the different way. And many people, the people who are already really pretty good at this, I watched a lot of oncologists who are really gifted at having these conversations, and we actually incorporated a lot of what we learned from them in the guide itself. But so for those people, they would take the guide and sort of make it their own. But for people who really struggle and have no idea how to do this, when they use the guide, their kind of performance went from sort of down here to way up. So it brings everyone kind of up to a better kind of, it ensures a better baseline level of performance. So what are some of the downsides of using a guide? Because there certainly could be some. So what would be, why did my feathers ruffle when I was talking about doing a palliative care checklist?
You feel like you have to go through all the checks instead of just letting things happen organically and seeing where the patient is.
Yep. So you have an agenda, and one of the most difficult groups I have to teach this to is palliative care or hospice people, because we're sort of trained to follow the patient and to follow their lead. And this is a little different because we're sort of going through a set of questions. What we recommend to people, and one of the things that's important about this, using this guide, is that it does need to be used with training. So is that we recommend if a patient brings up something really important, but you can't explore it in depth, is to say, that's really important and I want to make sure I get back to that. But we're going to move forward and we'll make sure that we talk about that at the end of the conversation. Other things, downsides of using a guide? Yeah.
Patients are different and
yes.
have different needs and don't like to be regimented in terms of, well, this is my agenda, rather than it's your illness. And I think that's a downside of the guide, is it feels that it's meeting the needs of the provider, not of the patient.
Absolutely. And this is one where I feel like I had to sort of make peace with the greater good. Because what I saw happening for the most part in medical practice is people thinking that conversations about end of life had to do with procedures. Do you want a feeding tube? Do you want do you want to be intubated? Do you want, and really, I don't think that's what those conversations are about. And by using this guide that's sort of open-ended and more, it's structured, but it's open-ended questions that are more about patient-centered values. It sort of flipped that. So I had to sort of make peace with that we do have an agenda, but it's a patient-centered agenda. Does that make sense to people? Okay, so, all right. So this is the guide, and I'm not going to go through it in depth. It's in your packet right now because we're going to go through it in depth later. But it's really a lot of pretty standard advanced care planning questions. The hardest part of putting this together was keeping it to a discrete number of questions. We kept wanting to make it longer and longer, and you actually can't do that. So that was a challenge. So then, after putting the guide together, we actually spent a long time thinking about what are all the places where we can sort of miss this conversation happening. And so we came up with tools. I think this is not working, but we came up with different tools. We came up with a clinician reference guide that had all sorts of scripting for different scenarios, because what we found in our trainings were that clinicians were furiously scribbling down everything we said. Oh, that's a great phrase. Let me scribble that down. So we put it all in one place, and all of our materials are available freely on the web. You just have to sign up, and I'll show you that website at the end. But the clinician reference guide is about a 10 or 15 page guide that goes through different scenarios and gives suggestions of what you could say. We have some patient preparation materials, so we would tell people before the conversation, we're going to have a conversation with you about your values and goals. These are some of the kinds of questions we might ask. You might want to bring a family member. So, and then a family communication guide. It gives suggestions of how to talk with your family about a serious illness. Then our training was intentionally 2.5 hours, and I'll go through what that 2.5 hours entailed in a minute. And then the main part that I spent most of my time on was the system change piece, and it was really hard. Trying to get the system change piece in place was a lot of work. So first, we wanted to be able to screen patients and identify patients that should have this conversation early. So I went to, the way Dana-Farber is structured is it's by diseases. So there's a breast oncology group and there's a sarcoma group. And so I went to the breast oncologist and said, this is our idea for a project. Which patients do you think you want to pick? And they initially picked we'll pick people on third-line chemotherapy. If they're on this drug, then they should have this conversation. So we started with that, and then we went to the sarcoma group, and we asked them what they wanted to use, and they wanted to use the surprise question, which is, would you be surprised if this patient died in a year? And it turned out that using the surprise question was actually a lot easier than using sort of different chemotherapies. So what we did is we kind of gave clinicians a list of their patients and asked them the surprise question. And for anyone that they answered no, we asked those patients to enroll in our trial. So then once I figured that if we train people, that really wouldn't be enough. We would sort of need to remind them or sort of in some ways nag them to do the conversation. So we came up with an idea to email them the day before they were supposed to have a visit with the patient that was enrolled in the trial. And then we also took the guide and put it on their billing sheet for the day. So they had to sort of actively ignore it. And we also told them, I didn't want to be too unpopular, so I told them, you don't have to have the conversation today, but if you don't, just tell us why you didn't do it. And I thought that by and large it would be because they didn't have time, but mostly it was because for 25%, only 25% of the time did they say it was because they didn't have enough time. 25% of the time they said the patient was actually too sick. And then about 25% of the time was because of logistical issues, like the family wasn't there or things like that. So we collected a lot of data about all the different steps in the process. Then they have the conversation using the guide, and then the other piece that drove me crazy was that when I was doing palliative care consults, if I wanted to find out what an oncologist or what a PCP or what a cardiologist had talked to about this with their patients, I would have to sift through like thousands of notes. Like you'd be looking through notes and you could never find it, or you sometimes might find it and there might be this little blip. So what we really wanted to do was create one place in the electronic medical record where everything about this could be, and that anyone could document there, nurses, social workers, but anything that was related to someone's values and goals would be in one place. So we did that, and that was no small feat either. And then we switched to Epic and we had to start all over again, but which is still a work in progress, but it's getting there. And then we had the patient and family resources, the different guides, et cetera. Okay, so the trial itself had many different components, really, and all of it's hard to say which components actually contributed to the outcomes. But as you can see, we picked the patients with less than a year prognosis. We trained the clinicians 2.5 hours. The patient got warned they were going to have a conversation. We bugged the clinician to do it. They had it, and then they documented it. So all of our oncologists and nurse practitioners and PAs were eligible to participate. We had a 70% participation, which I was kind of shocked. When a tool first asked me if I wanted to do this, I was scared that no one would do it. And he was like, well, if you're worried, then I think you'll get it done. So we were able to get quite a few people to volunteer. And then we randomized. And the way Dana-Farber works is one nurse practitioner, for the most part, works with like 2 or 3 doctors. And so we randomized by nurse practitioner. So the nurse practitioner, the doctors that worked in a team, they would be trained, and then another group of nurse practitioners and doctors that worked in a team would be randomized to not be trained. And so we looked at the patients of the clinicians that were trained, and that was our intervention group. So I talked about the surprise question. We also decided to just include English-speaking patients because we thought it would be too complicated to be using translators, and we also excluded patients with cognitive dysfunction. To look at feasibility and acceptability, we looked at how our training was evaluated. We looked at the triggers and how much clinicians use this. And then we asked the clinicians whether they found this acceptable. We also did an extensive chart review of the patients who had died in the study. And then we also, when patients were admitted to the study, they had a long questionnaire. We asked about many things, but one of the things we asked about was anxiety and depression. And then we actually followed the patients every 2 months, and they did surveys either through the mail or online. And then we also asked the patients whether they found the intervention acceptable and asked what kinds of behavioral changes they made. So, and like I said, they were done every 2 months. The intervention patients had one additional survey, which was 1 week after they had the conversation with their provider. And just to be clear, all of you know that these conversations are iterative, so they, you start and they happen over and over again. We counted a conversation as complete once the clinician answered all the questions in our electronic medical record module. So the clinician training, we picked 2.5 hours really purposefully because we didn't think we could get oncologists for any longer than that. And we weren't really sure if we could really make a difference in a 2.5-hour training. But I think one of the things that we found is that the guide in and of itself is reinforcing. So we taught people to use it, but then they had sort of this thing that kept them on track later after the training. So the way the training worked is it was a half an hour of didactics. First we started with a reflection, and we asked the clinicians to share an experience where communication led to a positive or negative outcome for a patient and their family. And that was really to center people and sort of bring them into the room. They, oftentimes getting paged with chemotherapy orders, et cetera, but to really sort of stop and take a step back and to really concentrate, but also to get some buy-in from them. So then we would do a demonstration using the guide, and you'll see something similar to that here. And then we would talk about what it felt like to hear that conversation. Then the bulk of the time was with actors. We had people use the guide with feedback. So the bulk of the time was really, and it was a pretty high ratio. It was 1 facilitator to 2 to 3 clinicians. So they had a lot of feedback on using the guide itself. And then the last 30 minutes were just about how to enroll people in the trial, et cetera. Okay, so now I'll talk to you a little bit about what we found. Just to give you a sense of what people said. So some people really did some practical things, like making changes to my will, planning my funeral. The way they communicated with their family, so more realistic in my approach with my family and friends about my prognosis. Made a complete list of my last wishes, including that if I can't go to the bathroom by myself, I want hospice at home. I'm doing all the same stuff as before. I'm just feeling less anxious about it. Hope for the best, prepare for the worst. And then started thinking about what my priorities are in terms of my quality of life. And then lastly, the conversation just mostly brought me closer to my doctor. So in summary, we saw that the training program was viewed as effective. It was feasible. The conversation with guide was feasible to the patients and their family members, as well as the clinician. And in the patients who died, we know that more patients had a conversation. They happened about 3 months earlier, and they were documented in a place where we could find them. And they had lower numbers of anxiety and depression, and that they found the conversations worthwhile, and they actually did things a little bit differently because of the conversation. So there is some limitations to this for sure. We had people volunteer for the study, so we don't know how it would work if we said you absolutely have to do this. The patient selection process favored sort of healthier patients, so many of the patients died in the screening process. We don't necessarily know what the actual conversations were like as opposed to how they were documented, and they only happened at Dana-Farber, and they were with English-speaking patients. So right now, we're sort of, we know that this sort of long process of identifying, training, having the conversation, documenting, resulted in more, better, and earlier conversations and better well-being for the patients, so less anxiety and less depression. But one of the things that we still want to look at is whether what kind of care the patients received and whether it matched their goals. So goal concordant care is just sort of a fancy term for did they get the kind of care that they wanted, and we're still looking at the data for that, and we don't have that finished yet. So I work with a really big team. When I started this project 4 or 5 years ago, it was myself, and I hired one assistant, and now it looks like this. It's been really exciting and fun, and I've also learned a ton from doing presentations like this and people like you. So I'm happy to take a few questions before we move on to the next section. Yeah.
I was curious if the clinician was always known to the patient, if they always had a relationship, or if it was ever de novo.
We actually made sure that the clinician and patient had always had 4 visits before they had this discussion, at least for this trial. And we've actually implemented in other areas now. I'm just showing you this because this is what we have the data from, but we've also done it in primary care, and we've also implemented it in long-term acute care hospitals. So.
It looked to me like a lot of the reduction in depression anxiety happened after the patient got materials, but before the actual conversation.
That's a great question, yeah. So we think that potentially the training may have affected how the clinicians were interacting with their patients. So we're still looking at that and trying to figure out the statistics, and I'm really glad that we have a very good statistician at Harvard to figure that out. So, but we think that essentially we think training may have changed the conversations even beforehand. Yeah.
I think that you said in the selection of the participants, about a third of them chose not to participate.
Yes.
Any feedback on why not?
It's a great question. We're not allowed to ask. Our IRB won't let us ask. Once they say they don't want to be part of the trial, we can't ask them anything else or look at their data. So it's a great question, though.
So just a comment on the 20 minutes, which can seem like a very long time, but I think most clinicians would not hesitate to spend 20 minutes talking with somebody about chemotherapy, or about some other complicated type of testing or protocol. So I think it can be found if there's a will.
Absolutely, absolutely.
I'm going to counter that one. I think we have a fixed amount of time, and these people have a fixed amount of time to live, and I'm wondering what they didn't get during those 20 minutes. Like in the control group, they got something else instead. What was that?
It's a great question. I mean, we don't know. Essentially, they would probably just go home from their visit.
But the doctors weren't sitting around. Assuming these doctors have a full schedule,
right?
They don't, and assuming that the time came from somewhere in their care,
right? And it's a great question, and I think probably it meant that our oncologists were there 20 minutes later during the day. And it's what's up? And you would, right, so we never triggered more than 1 patient a day. So we didn't really, and generally they would have one or maybe 2 patients a week on this trial. So I think it's really important. The other thing that we saw, burnout is a huge issue for oncologists, and I think one of the things I wished I had measured at the beginning of the trial was the burnout in the clinicians before and after. But one of the things that we definitely saw anecdotally was that many of the oncologists that felt like these conversations were really meaningful for them and really made them feel like this is why they went into medicine, and really kind of took them back to a time when they were sort of more idealistic and less sort of battered by the everyday things that happen in an oncology center. So, but I wish that's a regret I have about what we measured. Yeah.
Same clinicians see both sets of the patients? I mean, how did you control for, once you get this training, it fundamentally changes how you practice. How do you control for that?
So the way that Dana-Farber works is they work in these kind of clusters, so that a nurse practitioner works with 2 to 3 other doctors, And then that patient is always kind of cared by that team, so that they rarely ever cross over. We looked at crossover and it happened like once or twice. So they're really fairly separate. So yes, you're absolutely right. There is a lot of potential for people to be kind of unblinded, but we really didn't see the other oncologists that were in the control group going and stealing the guide and trying to use it, okay? We did try to keep it under wraps for the portion of the trial, but they're busy, and if you're not like putting it right in their face, they're generally not doing it, so, yeah. Oh, yeah.
Quick question. You mentioned the inefficiency of screening in a population of people with serious illness, and we have that same issue in primary care around screening for people who might not need contraception or who do need contraception, and have integrated the concept of one key question that can sort of help you sort, like, are you or any of your partners planning on getting pregnant in the next 1 year?
Right.
Ironically, the same interval, and it just raises the concept of, is there a one key question for this demographic of those with sentinel disease?
Right. And I think we had hoped that the surprise question would be that one key question, but what we found is that in primary care, when we asked our primary care clinicians, and we did a separate sort of implementation trial of this program in primary care, and what we found was that when we asked them to do that, they didn't like the "would you be surprised if this patient died in the year?" And we changed it to 2 years. So would you be surprised if this patient died in the next 2 years? And we're still looking at the data to see how accurate it is, but I think it might be better to I think there's ways to identify these patients with claims and labs and other things where we could actually have a flag in the medical record, like this patient might be at risk of dying in the next year or two. That would be a better way, I think, because if I were to use my time for the clinicians, I would rather them use it having conversations than screening patients. So I think we still have work to do on that piece. Maybe the last question, and we should probably, how are we doing on time?
We're good. Just this last
We're good.
question,
Okay.
and we'll move on.
Okay, great.
I was wondering if you looked at all at how this information was shared between, for example, the oncologist and the primary care provider, or various providers of various specialties who are all caring for the same patient.
So, the way that it generally happens, at least in Boston and at the Brigham and Dana-Farber, is that there's a lot of emails that go back and forth. But one of the things that was really interesting about putting this module in there is that, and this is one of the ways, once we opened up the trial and let people sort of see what we were doing, people would cut and paste what they had written in the module and put it in their email and send it to the other provider and be like, this is what I talked about. And then people would start using so that was one of the ways that we've seen sort of it spread. But it's still a challenge. I think, the who's responsible for the conversation. At Dana-Farber, the oncologists really see themselves as responsible and do the conversations and will work with the PCPs. But generally, it's the oncologist, just in that particular culture. Okay. I think we'll move on to the next portion.